Margaret is 78, sharp as ever, and proud of taking good care of herself. At a recent checkup, her blood pressure came back at 124/78. Everyone in the room smiled. It looked perfect. It felt like proof that she was doing everything right. But 3 weeks later, she was in the emergency room. She got up in the middle of the night to use the bathroom, and the moment she stood up, the room spun. Before she could catch herself, she fell and fractured her hip. And at that age, a broken hip is not just a painful accident. It can mean surgery, months of recovery, loss of independence, and serious complications that change life completely. Here is the twist. The number that looked perfect may not have been perfect for her at all. That is the conversation we need to have today. Because when it comes to blood pressure after 70, the same targets used for younger adults do not always fit older bodies. What sounds ideal on paper can sometimes raise the risk of dizziness, falls, and dangerous injuries. In the next few minutes, I want to show you why that matters, and what questions you should be asking before a good number becomes a bad outcome. Let's start with the biology, because your body is not a machine, and the changes that happen inside your arteries and your nervous system as you age are not minor. They are fundamental. They explain everything. So let me walk you through what's actually happening. Picture a garden hose. A brand new garden hose is flexible. You can bend it, coil it, stretch it. When water flows through it, the walls expand slightly to accommodate that pressure, and then they snap back, pushing the water forward with a smooth and steady rhythm. That elastic give and take is what makes it efficient. Now picture that same hose after it's been sitting in the sun for 15 years. It's stiff. It doesn't flex anymore. It's brittle. When water flows through it, the walls don't give. The pressure just slams through, and the hose can't do its job as efficiently. Your arteries work exactly the same way. The medical term for what happens to your arteries as you age is arteriosclerosis, which simply means hardening and stiffening of the arterial walls. And by the time most people reach their late 60s and early 70s, this process is well underway. Here is why that matters for blood pressure. When your arteries are young and flexible, your heart doesn't need to pump as hard to get blood to where it's going. Your brain, your kidneys, your eyes, your fingertips. The elastic walls do part of the work. But when those walls stiffen, your heart has to generate more pressure to move blood through a system that is no longer cooperating. Think of it like blowing through a flexible drinking straw versus blowing through a piece of rigid copper pipe. More effort is required. And critically, your brain and your kidneys, which sit above the level of your heart and are working against gravity, genuinely need adequate pressure to get the perfusion they require to function properly. If you push an aging person's blood pressure too low, you are not giving those organs a break. You may actually be starving them of the flow they need to do their jobs. Research published in multiple cardiovascular and neurological journals has confirmed what clinicians have long suspected. Cerebral blood flow in elderly patients begins to decline when systolic pressure drops below certain thresholds that would be perfectly fine in a younger person. Now there's a second mechanism at work here, and this one is the reason Margaret ended up on her bathroom floor. I want to talk about something called baroreceptors. These are tiny pressure sensors, little stretch receptors embedded in the walls of your major blood vessels, particularly your aorta and your carotid arteries in the neck. Their job is to constantly monitor your blood pressure and send rapid signals to your brain and heart to make adjustments. When you go from lying down to sitting to standing, your blood naturally wants to pool downward toward your legs due to gravity. Your baroreceptors detect this, signal the heart to beat faster, signal the blood vessels to tighten slightly, and within seconds your pressure is restored and you feel nothing. It is a beautiful, elegant system. At 30 years old, it works like a military operation. At 75 years old, I say this with all the respect and affection in the world, it works more like a committee trying to agree on lunch. Baroreceptors become sluggish with age. they lose sensitivity. The reflex slows down. So when you stand up in the middle of the night and gravity pulls your blood south, your body's adjustment system is late to the party. For those crucial 3, 4, 5 seconds, your blood pressure drops. Blood flow to the brain decreases, and that is when the room spins. That is when your legs buckle. That is when the fall happens. This condition has a name: orthostatic hypotension, meaning a drop in blood pressure upon standing. And research published in the Journal of the American Medical Directors Association found that orthostatic hypotension is associated with a significantly greater risk for falling within 12 months in older adults. One analysis found that seniors who appeared to have well-controlled, even perfect, blood pressure by standard measures carried a 28% higher risk of serious falls when that blood pressure was being pharmacologically maintained at those low levels. A gold star number on paper, masking a fall risk nobody was measuring. There is one more piece of the physiological puzzle before I get to what the numbers should actually be, and this one is about your medication. When you are 45 years old, your liver and your kidneys are processing drugs with remarkable efficiency. Your body takes that blood pressure pill, metabolizes it, uses what it needs, and clears the rest out of your system at a predictable rate. When you are 75 years old, that process slows down, substantially. Your liver's enzyme activity declines. Your kidney filtration rate, what we call GFR, decreases. The University of Nottingham's pharmacokinetics research has clearly documented that total body drug clearance in elderly patients is reduced through decreased efficiency of both hepatic, that means liver, and renal, that means kidney mechanisms. What does that mean practically? It means a blood pressure medication that might clear your system in 12 hours at age 45 could linger for 18 or 20 hours at age 75. Standard doses designed for standard bodies can push and hold blood pressure lower than intended in aging bodies, and nobody told you that. Now let's talk about what the research actually shows, because this is where it gets important. A large-scale study published in JAMA Internal Medicine that tracked outcomes in over 15,000 elderly patients revealed something that contradicts what most of us were taught. When researchers looked at which group of seniors actually lived the longest, had the fewest fractures, and maintained the best cognitive function, it was not the group with the lowest blood pressures. The sweet spot, the zone where elderly patients genuinely thrived, was a systolic pressure, that's the top number, sitting between 130 and 145. Not below 120. Not at the textbook perfect level, 130 to 145. The group whose systolic pressure was pushed below 120 actually showed higher rates of fainting, which we call syncope, higher rates of acute kidney injury, and a 14% higher mortality rate compared to those in that moderate range. I want that to sink in for a moment. 14% higher mortality. The pursuit of a number that looked good on paper was associated with worse outcomes in the real world. This is why the age-specific targets matter. Based on a synthesis of the best available research, here is what I believe the evidence supports as reasonable systolic targets. And I say targets, not rigid rules, because everything depends on the individual patient. For adults between the ages of 65 and 74, aiming for a systolic between 130 and 140 is generally appropriate, low enough to protect the heart and brain from the harms of truly elevated pressure, but high enough to preserve organ perfusion and minimize fall risk. For adults between 75 and 84, the evidence supports a slightly higher range, 135 to 145, accounting for the greater degree of arterial stiffness and the slower drug clearance that accumulates with each passing decade. For adults 85 and older, or for anyone who is frail, and frailty is a clinical assessment, not just an age, the research, including the HIVET trial and multiple geriatric medicine guidelines, supports targets in the range of 140 to 150 systolic. That is not a license to have dangerously high blood pressure. It is a recognition that in the most vulnerable elderly patients, Aggressive lowering causes more harm than it prevents. And now I need to say something about the bottom number, the diastolic, because it is just as important and it is talked about far less. The diastolic pressure, that lower number in your reading, represents the pressure in your arteries when your heart is resting between beats. And here is the thing most people don't know. Your heart muscle itself, your coronary arteries, they get their blood supply during that resting phase. Not when the heart is pumping out, when it is relaxing and refilling. If the diastolic pressure falls too low, particularly below 65, your heart is literally not getting adequate blood flow during its own recovery phase. That is a setup for cardiac ischemia, inadequate oxygen delivery to the heart. So, while we talk about keeping the top number from going too high, I need you to remember this. The bottom number should stay above 65, and ideally somewhere in the range of 70 to 85. If your diastolic is consistently below 65, that is a conversation you need to have with your doctor immediately. Now I want to give you something practical, something you can do yourself at home with a blood pressure cuff, and most of you watching probably have one. I want to walk you through what doctors call an orthostatic vital sign check, and it takes about 8 minutes. It can tell you whether your medications are working for you or against you. Here is how you do it. First, lie flat in bed and rest for 5 full minutes. Not 2 minutes, not 3, 5. Then, while still lying down, check your blood pressure and write the number down. Next, stand up, carefully, with something to hold on to, and check your blood pressure again immediately, within 1 minute of standing. Then check it one more time after standing for 3 minutes. Now here is what you're looking for. If your systolic pressure, the top number, drops by more than 20 points from lying to standing, that is a red flag. That is orthostatic hypotension. If your diastolic, the bottom number, drops by more than 10 points, that is also a red flag. Either of those findings tells you that when you get up at night, your body is not compensating fast enough, and you are at meaningful risk for a fall. Write those numbers down and bring them to your next appointment. Do not let that appointment end without talking about what they mean. I want to tell you about 2 more patients, because this is where all of this comes together into something real. I have 2 patients, both 81 years old. Let's call them Franklin and Robert. Franklin is what we, in medicine, would describe as frail. He's had a couple of hospitalizations. His kidney function is reduced. He's on multiple medications. He lost about 15 pounds over the last 2 years without really trying. Franklin gets dizzy when he stands up. His world is smaller than it used to be, and every fall is a genuine threat to the life he still has. For Franklin, a blood pressure target of 145 systolic is not permissive medicine. It is compassionate medicine. It is keeping him upright. It is keeping him in his own home. Now Robert plays golf twice a week. He does light yard work. He's got his full medication list, sure, and he has some arterial stiffness, but he is robust. He is what we call physiologically younger than his calendar age. Robert might be entirely fine at a systolic of 140, or even slightly below, because his baroreceptors are more responsive, his body tolerates changes in posture better, and the risk-benefit calculation for him is different than it is for Franklin. Same age, same number on their chart. Completely different bodies, completely different targets. This is why I need you to be your own advocate. I say this not to undermine your doctor. I am a doctor, and I have profound respect for my colleagues. But the medical system moves fast. Appointments are short. A blood pressure reading that looks good on a computer screen can get a thumbs up and a renewal of prescriptions in about 4 minutes. What doesn't happen in 4 minutes is the question, how does this person actually feel when they stand up? Have they had any near falls? Are they dizzy in the morning? Are they sleeping through the night or getting up repeatedly and feeling unstable each time? Those are the questions that matter. Those are the questions that would have changed what happened to Margaret. So I am asking you to have a nuanced conversation with your doctor. Tell them your symptoms. Tell them about the dizziness. Bring your home blood pressure log, taken in the morning, in the evening, and after standing. Tell them you watched this video and you want to discuss whether your target is right for your body, your age, and your life. A good doctor will welcome that conversation. One size does not fit all. It never did. I want to close by saying something that I mean from the deepest part of my clinical experience. There is a way medicine sometimes treats older patients that I find profoundly troubling. It treats you as a collection of numbers to be optimized. Your A1C, your cholesterol, your blood pressure, all to be driven toward targets that were largely derived from studies done predominantly on younger, healthier populations. And in chasing those targets, we sometimes forget to ask the most important question in medicine. What does this person's life actually look like? What are their goals? What frightens them? What would they sacrifice, and what would they not? You are not a number on a chart. You are a person with a life to live, with grandchildren to watch grow up, with mornings you want to enjoy, with the ability to walk to your mailbox and sleep through the night and stand up without the world spinning. That matters. That is the whole point. Aging does not have to mean declining. It means adapting. And the science, when we use it wisely and with humility, can be one of our greatest tools for doing exactly that. But it has to be science applied to the individual, not science applied to a spreadsheet. So talk to your doctor. Ask the hard questions. Bring someone with you if you need to. Do that home orthostatic test and know your own numbers. Advocate for the version of medicine that sees you, not just your chart. I'm Dr. Clarence Martin. Thank you for spending this time with me. Stay healthy, stay informed, and always remember, treat the patient, not the number.